IVC view and measurement. IVC view and measurement in echo, it gives us a lot of information, and many situation is critical. One of them is for evaluation of the right atrium pressure. This method is almost correspond with the measurement in catheterization and is accurate. With this measurement, we evaluate the central venous pressure, how much, if the patient is over volume load or not, and in the treatment is very important. And even for the pulmonary hypertension, evaluation for pulmonary hypertension, right heart failure, and in management is a key for correct management and treatment, and even for the tricuspid regurgitation severity. For getting IVC, as you know, IVC anatomically is on the right side of the vertebra, and the aorta is almost next to it on the left side of the vertebra, so, and in the midline. So we get in for this view, we put the probe at the midline below the xiphoid process, pointing marker to the 12 o'clock or face of patient. Then meanwhile, we ask the patient breathe in slowly, gently. All of a sudden, IVC will shows up clearly. In a good image, IVC should be open all the way. You have to show it all the way. If it's not, for shortening, you cut it, you don't see it. Just with twisting, fix it. If when twisting, it disappears when you are fanning too, just fan opposite way, left or right, and keep it the right alignment, IVC show up. And in your image, you have to show it partial of the right atrium, at least entrance of the IVC to the right atrium, and clear wall. And then you have to go for measurement. You have two measurements, one of them in inspiration and another in expiration. So you have to do it. The point that you have to measure it is the largest diameter at the point of the entrance to 2 centimeters beyond that. And your measurement should be perpendicular. Any spot that you use it should be perpendicular to the wall, not the image. You shouldn't measure, for example, this way. Is wrong. You have to measure, if this spot, this is way you measure it. Here is almost vertical. Here, if you measure it a little, this way. So in some cases, maybe proximal is not very clearly. You can go and do it a little right before the middle hepatic vein here show up, and then when you do it on the largest diameter, when the patients breathe in and breathe out deeply, you record it, save it, and see it loop. We go back, and the largest diameter and the smallest diameter, you measure it for collapsibility. But the better way for evaluation of collapsibility is, as the patient sniff, you put in the 2D or M mode. On 2D, when you are here, ask the patient do one sniff fast and strong, not too much strong, but fast, and you will see it's collapsing with the sniffing. Or do it M mode, put the cursor exactly perpendicular to the IVC at this level almost, and then you hit the M mode, and then you ask the patient sniff, and it show you very nice and clearly, and optimizing image, decrease gain, all those stuff, and then measure at the smallest, that's closing, and opening largest one here, and you evaluate the collapsibility. If you are dealing with the moderate to severe TR, you have to show it middle hepatic vein too, and put color always, and you can see and record it, and put pulse Doppler sample volume at the proximal of the middle hepatic, and then you get the the spectra of the middle hepatic. In this case is normal. You see W shape and three-phasic, 1, 2, 3. So three-phasic, but in another lecture we talk about the Doppler on the middle hepatic and right heart in detail. In many cases, you cannot get IVC in subcostal for many reasons. For example, patient has laparotomy, pansement on the belly, or has gassy, is not fasting, and or body habitus. You'll try with breathing and everything, still you don't have any nice IVC in the subcostal view. So you go, always there is an option, and in almost 90% in cases you can get from this view. This view is intercostal, right intercostal. You go put the probe at the mid or anterior axillary line, somewhere between 6 and 7 or even 8 at the intercostal, pointing the marker 12 o'clock, and between the intercostal you will see first lever, and from there pointing the probe to the IVC, to the midline of the patient. With fanning up and down, you can little IVC will show up, and if you are lucky and right angle spot, maybe you can see aorta too. So IVC and aorta in right. And if you put color, you can see the color on the both IVC and aorta, but here is because almost perpendicular to the direction of the blood flow, we don't see too much color because Doppler shift almost close 0.